So next we have Dr. Rais Bahrami to speaking on post-ablation surveillance.
Good afternoon. Thank you for the invitation, and I'm just going to dive right in. Disclosures. So as has been the theme with those preceding me, we obviously need more data in this field of focal therapy for prostate cancer treatment, specifically in terms of defining post-therapy surveillance, monitoring, and treatment decision-making or surveillance decision-making thereafter. We also need to use data as we acquire and develop it to define conformity in our practice patterns, to have a direction as a group, as a team. So I'm going to present my personal perspective and clinical workflow, some rationale, why it is, and how it has evolved. And then hopefully this will promote some thought and discussion with the ultimate goals of developing a best practice statement as a team amongst the experts in this room. So what are we lacking as a field? We are certainly lacking an NCCN guideline or something similar to it for prostate cancer in the domain of focal therapy, how to do it, how to select patients, which modality, the great talks that were given. But once we've ablated prostate cancer, how do we thereby follow our patients and make sure they're oncologically safe? How do we then make sure their quality of life is measured appropriately? And how do we care for them lifelong after our treatment? So there's quite a lot of variability after focal ablation for prostate cancer. PSAs, some do them every 3 months. We don't know what the PSA dynamic should be after certain types of modalities used. Some do 6 months, some do other intervals. A lot of this may be patient and provider driven. MRIs, we know there's a critical importance of some sort of imaging, which is often what's used to drive towards the focal therapy in the first place. But how do we define the cadence of doing imaging after ablation is complete? That's not just MRI, it goes into PET. Where does PET fall in terms of treatment decision-making up front? And thereby, what role will it play after treatment for intraprostatic definitions of potential persistence or recurrence of disease? And biopsy. I would advocate yes, there still is a role for biopsy at some point after the treatment. But when? How often? Should there be multiple? So what we have to look to is a September 2020 standardized definition of surveillance methodologies. It's an international multidisciplinary consensus statement, but again, an expert panel. Less driven on steadfast data, but it was based on data of the time and the experience of those leaders in this field. So I'll describe to you our UAB urology approach currently and the workflow, but also how we got to it. It really involves a changing practice that I've had as I've learned from my own experience as well as learning from the peers, many of whom are in the room. So I started by doing frequent PSAs, annual MRIs, and serial post-ablation biopsy procedures to make sure my patient was oncologically safe. This was my early programmatic experience. It's also largely driven by the consensus statement that I showed you from approximately 4.5 years ago. But comfort builds as we develop experience, especially with the negative predictive value of the in-field evaluation of MRI, and now I've incorporated PSMA PET imaging in approximately 1/4 to 1/3 of my post-ablation patients. The post-ablation MRI specifically will give definition in terms of targeted biopsy, and based on that biopsy pathology correlate, which we've reviewed in our multidisciplinary imaging conference, I've gotten a lot more comfort by doing away with many of the biopsies, decreasing the frequency of even the MRIs. So again, I acknowledge that I've evolved in my technique of surveillance after ablation. The environmental pressures really drove that. It was the patients that are saying, you've treated my prostate cancer. My first biopsy was negative. Why are you signing me up for another MRI and another biopsy? And I see Dr. Emberton, who's really led a lot of this, and doing a move towards a value proposition. The goal is really that shared decision making, whereby we chose focal therapy with our patients as the best treatment algorithm in that personalized approach. And then we have to now assess after treatment the morbidity of doing serial biopsies versus potentially finding clinically significant cancer, whether persistence in field or recurrence or independent occurrence somewhere else in the gland. So now I'll tell you our typical workflow. PSA 3 and 6 months after ablation. Subsequently, PSA at 12 months or a year out, coupled with an MRI. Now, truthfully, I'm only telling this group, but why do I get a PSA at 3 months and 6 months? It's based on my team's algorithm. My team is used to doing that after radical prostatectomy. My team is used to doing that after various forms of radiation approaches that our experts in rad-onc do. So it's just for simplicity. My patients ask me, what do you make of my PSA 3 months after? And I tell them, it's just a data point. I don't know what to make of it. And oftentimes I've seen it stay stable, go down 10, 15, 20%. In rare occasion, I've even seen it go up, even lasting to that 3-month period. And some of that depends on the treatment modality and how much tissue we treated. All patients currently at my institution are still undergoing a biopsy at 12 months. How do I get buy-in for this? I do this in pre-treatment counseling. I say it's part of your workup. You're signing up for this package under my care, and unless something really important happens between your treatment and that 1-year follow-up, you've already signed on the dotted line to move forth with it. Then based on that biopsy at a year after, if it's benign, I go just to PSA and imaging follow-up and no additional biopsies. A big change over the past 2 to 3 years in my workflow. We only do biopsies thereafter for cause. If there's cancer found, well, that pathology is going to define the course. Are they active surveillance worthy and safe? Are they retreatment, which is what I consider patients who would undergo another subtotal gland or a focal therapy? Or the word salvage at my institution, I mean whole gland treatment of some sort. So what if localized prostate cancer persists? As I showed in that last bullet on the previous slide, it takes us back to the drawing board. I'd say very little is lost. We have focal retreatment as an option in many of the patients, though this is an even newer frontier. In the domain of focal therapy, we're talking about retreatment with focal therapy is a smaller subset that we know even less data on. Then whole gland salvage options. Lesser conceived risks after focal therapy because it has not had the entire gland and surrounding tissues impacted like the radical salvage prostatectomies we know after whole gland radiation. So maybe too soon, may also be too close, but hopefully with our focal therapy, we leave our bridges intact. So what if there's regional or metastatic spread? So we're obviously surveilling and monitoring our patients after what we believe was a well-selected patient and a well-applied focal therapy treatment. But my argument would be, if in the short course, on the order of less than 2 years, if there were going to be any locally advanced regional or metastatic disease, this was a concept that the intraglandular treatment, whether focal or radical, was never going to be a success. This is that patient that we've all done radical prostatectomy, had pathologic T2, margin negative, obviously SVN nodal negative based on that pathologic stage, and the PSA recurs at some point, 2 years, 5 years, 10 years down the line. That just means we were not good enough to know about the occult lymphatic spread or circulating tumor cells. And in these cases, time will be the proving ground. Very much parallels the concept of focal, unifocal, muscle-invasive bladder cancer that undergo a partial cystectomy. In those patients, the outcomes are not derived whether or not a radical cystectomy or partial cystectomy was done often, but it was based on the fact that was there local disease or truly metastatic disease that we didn't know about. Same with prostate cancer. So next steps. Regardless of what treatment we're talking about, all will have different imaging findings afterwards. Would one unified follow-up pathway suffice? This is one thing that we have to define as a society and as an expert group. different treatment technologies that have already been presented here and more on the frontier. But the identical end effect goal is to kill cancer. Will that cancer look the same on various imaging modalities once it's ablated and destroyed and no longer viable? What is the time to achieving that true death and ultimate imaging finding? And then the variability that may last for a long time, well past the actual death of tissues. So again, our focal therapy missions are to decrease morbidity of treatment, but I would also say we have to be cognizant and decrease morbidity of surveillance. We need to maintain quality of life without compromising cancer control, just like we do with the ablation, but now mindful of it in the post-ablation surveillance. We want to catch the persistence within that 6 to 12 month period with that biopsy. We need to detect prostate cancer of a significant degree afterwards with a for-cause follow-up. And I beg the question, would we in the near future even give up that 1-year follow-up biopsy with better experience of what to look out for? So history repeats itself and pendulums swing. This is a borrowed slide by one of my great colleagues who's here today, but I do want to share the connectivity. So Hugh Hampton Young in 1937, from Baltimore, but published in a journal out of Birmingham, Alabama, discussing the role of a hemiprostatectomy potentially being sufficiently radical. Removal of only half the prostate with the seminal vesicle and vas may be adequate and entirely sufficient for cancer treatment. So I present to you an opportunity for the panel to go into questions. Thank you.
Thank you, Serge. That was a great talk. If we could invite our distinguished Q&A panelists, Dr. Peter Carroll, Mark Emberton, and Samir Taneja. We'll have our Q&A during this session.
I certainly have questions, but let's take questions from the audience first. Yes.
First of all, very lucky to have the three of you here as a panelist, and special thanks to those last 4 talks. Really, really fascinating, and obviously if those speakers have anything to add, please just stand up. Just wanted your guys' perspective on some early sort of evolution of the field as you've seen it over the last sort of decade plus coming to these conferences. We've seen a lot of evolution sort of spoken about during these talks. Do we do a biopsy post-treatment? How many biopsies pre-treatment? Sort of just interested in your perspective of sort of how you see the field evolving, where you see things going in sort of the short to medium term here in the future, and then obviously any sort of longer term perspectives. Invisible prostate cancer has been sort of a hot topic here, I would say, today. Is that where we're moving, and sort of what topics do you see us discussing in years to come here at these conferences?
A great question. I should make a disclosure. I'm Peter Carroll. I don't do focal therapy. I send a lot of patients to focal therapy. We have a big program, and we have a lot of data relevant to those questions. So go at it. I have some comments on that, actually, because that is a great question. But people who do focal therapy may want to comment.
Yeah, I mean, so it's a huge and very open question, great one to start with, but we could spend the rest of the afternoon discussing it. So that the thing that's kind of intriguing me at present, and I'm very glad that Peter's chairing this, is the relationship between what we used to do as surveillance and focal therapy in a world that's changing, where the world is becoming more about lesions and less about random biopsies, and how that changes what we do. And of course, the two are both attempts to preserve tissue. The focal therapy patients historically have been at higher risk, or should be, the focal therapy patients have all got lesions in my book. You need to have a lesion to aim at. And I suppose the question, the kind of modern current question is how do we manage lesions? They're a relatively new entity. We don't fully understand their determinants. We don't fully understand their fate. We're learning that they are kind of high-risk things. We're learning that they all progress. Is it reasonable to watch a lesion and watch it grow, therefore, and increase the capture abutment, increase in volume, or when we see a lesion for the first time, should we treat it early because it will never be that small ever again? Remember with active surveillance, it was kind of a form of delayed selective intervention. We were trying to avoid surgery in a proportion of patients. I'm not sure that applies to a lesion. Or I think it's certainly worthy of debate of how we approach, evaluate, and manage a lesion. Is that a reasonable thing to do, or should we get on and treat it? And that's very different to the traditional philosophical conservative management of low-risk disease. And of course, if you stop doing random biopsies, Gleason 3+3 disappears. In the reimagined screening study where we just did targeted biopsies, only 2 out of 330 men, so less than 1%, got a diagnosis of Gleason 3+3. So that, for me, is a really interesting changing landscape.
But Mark, wouldn't you say that beyond just a lesion, a visible entity, you can describe that lesion in much more detail nowadays with grade, histologic subtype, molecular markers. So I'm not sure just having a lesion alone suffices to treat it, but maybe take into account all these other things as well.
And I think that cuts to the point of how the field has changed, Jonathan. In my time, I've been doing focal therapy less period of time than Mark, but probably about going on 15 years now. And it's evolved largely because of our technology evolution, which has better defined the practice of focal therapy, the risk stratification aspect. So early on, it was all biopsy driven, right? Before we had good imaging. I think one of the major changes has been now, for the most part, it's an image-guided paradigm, right? We define the index lesion with imaging. We define our treatment plan with imaging. And as the imaging gets better with PSMA and molecular imaging and other attributes of MR, we might better define which lesions, like you said, Peter, need to be treated. Maybe it's radiogenomic signatures as we understand the genomics better. I think the other thing that's changed is the goal of the treatment. Early on, we viewed it as a treatment alternative to radical prostatectomy. I view it now more as a more appropriate treatment for a subset of patients who maybe wouldn't have benefited as much from radical prostatectomy. I think PROTECT has taught us there's clearly a large swath of favorable risk patients who are at very low risk of prostate cancer mortality, but very high risk of radical therapy during their lifetime. And maybe this is a treatment well suited for managing those patients rather than eradicating. And I think the follow-up, what Sarush said, pretty much Sarush is a smart guy. He came to the same conclusions as me without ever talking to me, that early on we used to biopsy aggressively. But what you learn is the biopsies may find cancer, but it's not always cancer that you will act on, right? So if you do a biopsy and you find 2 millimeters of GG2 and you elect to keep watching anyway, maybe you didn't need the biopsy at all. So I think biopsy de-escalation and using more imaging in follow-up, using biomarkers in follow-up will be the other big evolution, so that it truly becomes a seamless paradigm of less aggressiveness and efficacy within the context of the goal of the treatment, which is not no cancer, it's hopefully no cancer death, if that makes sense.
So Samir, in active surveillance series, we had to learn that by following patients very carefully. And only with time and very good data could we de-escalate quite a bit. The concept of not biopsying is one I would be cautious about. As certainly as you evolve to better patient selection and you try focal therapy to a more inclusive group of patients, I think at least that early biopsy could be important. Certainly the series at UCSF, that 1-year biopsy appears to be important, even for MR invisible lesions. So we think, I think at least a biopsy, especially if you're treating a higher risk patient.
Well, so just to be clear, I do exactly what Sarush said. I still do, for me it's not 12 months, it's 6 months. But I do a confirmatory biopsy to assess the adequacy of my ablation, largely because I'm interested in retreating them if I didn't get it all. So I want to know that I got the index lesion. But after that, it's largely for cause, unless we're in a clinical trial. The Vapor 2 study, we're doing biopsies every 2 years. But for the clinical practice patient who's not in trial, after the initial assessment, I have gone largely to for-cause type of biopsy.
Since you mentioned imaging, let me ask you a quick question. Several people have mentioned PSMA PET, and that's certainly what we're trying to do more of PSMA PET in these patients. Is PSMA PET being done routinely now at least to gather more information about this? Because when we've looked at our results at UCSF, adding PSMA PET and MRI better maps the tumor. So are you doing it, or is it considering it?
I can answer quickly and then let's see what Mark thinks. So I do it not routinely in everybody, partly because I think when you do it in more favorable risk patients, you probably end up with a lot more false positive findings that you need to chase if they're in the equivocal SUV range. But everybody who's GG3, I do focal therapy on a small subset of GG3 patients who have low volume disease. It gives me a lot more confidence that those people are appropriate. So I use it in my GG3 patients for selection. I've not yet used it as a routine, but I think it's a very important area to explore, to say, yesterday we discussed that a little, and the question I got up to ask, but the speaker had left, was what do you do if you have a unilateral PIRED4, you biopsy it, it's GG2, now the patient gets a PSMA PET, and you have sort of maybe equivocal or moderate uptake in the right anterior zone opposite that left-sided lesion. Do you rebiopsy? Do you tell them they're not a focal treatment candidate, or do you go ahead and treat and sort of ignore that finding?
So I'm the same. I so routinely do a PSMA PET on GG3 or more. I find it very helpful in the older man that we're trying to avoid hormones and radiotherapy, who might have a Gleason 4+5, and the PSMA PET caps the risk, and normally you get a double hit, so the MRI and the PSMA PET are almost entirely concordant. But you're quite right, any test you do can come up with kind of any result, and sometimes you get a discordant result, and I think if you do it, then you have to be prepared to follow that up and biopsy all the lesions, wherever they come from. And remember, we've got lots of inputs for lesions now, so your ultrasound, PSMA PET, and MRI. The studies show them all to be roughly equivalent, but there's some incremental benefit of doing more than one. And so they all miss, and I think they're quite interesting because they all extract different elements from the tumor. And therefore, they overlap a lot, but each one will miss some.
So Peter, you probably have more PSMA experience than us at your center. What is the prevalence of PSMA discordant lesions in men who have favorable risk disease?
Usually it's very concordant in the prostate. So usually it lights that, certainly for the focal candidates, focal therapy candidates, usually it lights it very brightly. Some very nice images, get you confidence. I think if you saw a contralateral anterior lesion that lit up, I agree with Mark, I'd probably biopsy that. Where these become problematic is, and they're trying to look at the presacral ganglion, these false positives, is usually presacral ganglions and rib lesions. These are, we see a lot of false positives. Question?
Yeah, hi, thanks. Preston Sprankle from Yale. To follow up on kind of Sarush's talk and something that Dr. Taneja was just talking about, in surveillance, so in these patients post-ablation, if you do find small amount of volume, small grade group 2 or grade group 1, are you following those patients on surveillance then, or are those folks that you sort of, what is your for-cause target for those guys for another biopsy?
Yeah, so Preston, it's a really good question that I don't know if I have the right answer to, but my viewpoint has been that if it's a margin failure, so if, let's say I find that small amount of GG2, I'll usually encourage the patient to have a second ablation to complete the margin. If it's a focus of disease elsewhere in the gland, unrelated to the ablation, because I also do a systematic sample at that time, good or bad, then it's back to my initial surveillance criteria. So if that person has a small amount of GG2 unrelated to the imageable lesion, I've generally just done surveillance on those patients, and then I use their PSA kinetics as I would in any patient who's on surveillance.
So I just to say that there's legitimate professional disagreement in the room. So, preoperatively, I only biopsy lesions, as I've shared with you today already. Postoperatively, I only biopsy lesions. So we'll watch the prostate very carefully with yearly MRIs for 3 years. If they don't recur by year 3, and if they do develop an abnormal gadolinium in the scar tissue, we'll certainly sample that if they'll let us. If they don't develop a recurrence by year 3, then they're very unlikely to. And then I think it changes. So the question changes. So for 3 years, every year I'm saying, have I got it all? And then after year 3, I'm changing the question to, have you developed a new tumor? And so I think as the question shifts, so can the interval. And so, you're basically screening for new disease. And then I try and relax the interval thereafter. Some people get very addicted to yearly MRIs. If they've got a stable PSA, it's easier to relax the MRI interval. If the PSA is all over the place, it's very hard to do. But I try after year 3 to get them to 18 months to 2 years, if I can.
So I don't think we really disagree. We're just coming to the same conclusion differently, right? You're waiting 3 years to decide if they need treatment. I'm retreating within year 1. But then after that, we've had very few patients with 2 ablations who've recurred. So then it comes back to that looking for new lesions. But just to play devil's advocate, so if you only do a targeted biopsy in a gentleman who comes to you for primary diagnosis, doesn't that make every man a candidate for focal therapy?
No, some people have got, I showed one just now at the lunchtime meeting with kind of bilateral disease, they'll go to surgery.
So the threshold is more than 1 lesion?
Yeah, I think so. I mean, as you know, once you cross the midline with focal therapy, you start to eat into the kind of functional aspects. And there's a thing about multifocality, is focal therapies for focal disease. I think if somebody comes into you at multifocal, that they're probably going to develop a 4th and a 5th lesion in time. It's different. Now, we don't yet understand, and I apologize, I'm repeating myself now from the lunchtime thing. When you first see a patient and you first see their lesion, we don't know where we are in the story. Is this the beginning of a story? In other words, are they about to manifest several lesions over the next year or 2, but all you can see now is 1? Are they in the middle of a story? So they develop 1 lesion, they'll develop another one the next decade. Or are they at the end of a story, that they've been living with a nice stable lesion in harmony with their immune system for several years? You've just detected it, you ablate it. It was a kind of one-off feature. And you'll see them 10 years later and they'll be free of disease. And of course, we don't know where we are in the story when we first meet, and we have to make a therapeutic decision then. So I think the next 10 years, and we've had several conversations with colleagues in the last day or 2, is about understanding and phenotyping individuals, back to the biomarkers, as to who is likely to develop more than 1 lesion over the medium term, because they might be better served with another form of treatment, or they might need some form of adjuvant care. And I think the places to look are obviously the germline, the mutational landscape of the normal tissue, possibly the mutational landscape within the cancer, although we don't know that yet.
You follow up on that?
One quick follow-up. Thanks. Dr. Emberton, you're clearly implying that MRI is adequate to detect any recurrences in the post-ablation setting. I haven't felt that way, so could you kind of share your rationale for that? I don't know if everyone else agrees and I'm the outlier, but I haven't felt like I've seen enough, and maybe it's just our studies haven't shown that yet.
Yeah.
But Mark, you do a biopsy at year 1, correct?
No.
Oh, you don't? Okay, so we're in the same camp.
Unless they're in a clinical trial.
Yeah.
So the clinical trials required
Okay.
it, but the doctors all refused. We've published on this. The gadolinium scan in the scar tissue is exquisitely sensitive. It's dark and there's no diffusion signal. The moment there's some perfused viable tissue within that scar tissue, there's an alert, and it's really easy to see. I mean, I showed one in the lunchtime thing, and we watched that one for a year, it doubled in size in a year, but that was 0.05 cc's in volume against a very dark background. I mean, you can see those from across the room. So, the trouble with biopsying a normal-looking prostate is you don't know the fate of these subclinical lesions. You don't know if they would ever have manifest. They've still got a lot to do, as Claudia and I were speaking earlier, to become real tumors. They've got to overcome the immune system. They've got to develop a blood supply. They've got to have some mutations that aren't hazardous to their proliferation. So there's a lot. And so treating subclinical disease worries me because of the risk of overtreatment.
Yeah. One quick comment, small volume secondary pattern 4 is a low-risk tumor. So I think we got to be a little cautious about dichotomizing prostate cancer. So on a CAPRA score, 0 through 10, validated around the world, going from 3.3 to 3.4 gets you 1 point. Volume makes a difference. But just having a secondary pattern 4 small volume, those are generally low-risk patients. Question?
Yeah, actually a question for each of you. For Samir, what's the practical implication of retreating somebody in the immediate setting in the American insurance environment? I always worry about that, and it may be more successful depending on where you are to take a different strategy and retreat somebody a year or two later. And then, Dr. Emberton, people seem to be challenging your approach, and we've heard this about what you do. But can you remind us about your cancer-specific survival using your approach?
Yeah, well, we haven't had, the best data we've had is the 15-year data that we published 2 years ago. That'll be refreshed. The 5-year data, I showed that at the lunchtime meeting. Remember, this is all cases, all comers, pre-MRI, everybody's learning curve. And so 83% were free of disease at 5 years in that study. Now, it's a multi-center, multi-user study. There'll be a range of follow-up regimens. It's not a trial. But that's appeared stable over time.
Yeah, and I'm not trying to put you on the spot. I'm trying to remind everybody to compare that to what we get from radiation or radical prostatectomy.
Correct, yeah. I think cause-specific survival, even I've done thousands of prostatectomies, and even high-risk patients, cause-specific survival is quite good. So I think you want to look at the morbidity of treatment, systemic disease, hormonal therapy. We have a lot of questions. Any additional questions at all?
Comment about the insurance?
Yeah, so Steve, it depends what quarter of the year you ask, because the insurance policies just keep changing, and you're right. When I did this a decade ago, we didn't really get pushback on retreatment. Now some third-party payers do push back, and that's not a timing issue. That's straight up, you can't do a salvage ablation on a previous ablation. You can do a salvage ablation on radiation, yes. Ablation, no. So it just keeps changing. So you're right, down the road, the vapor trial we're doing will be a very good demonstration of retreatment, because you're allowed to retreat up to 3 times in that study. And if you show over 5 years that by doing retreatments you're avoiding radical therapy, maybe that catches third-party payers' attention. And
Let me ask some questions that come up a lot when I see patients. One, this issue of double tap or single tap. So is there equipoise on this? Do you treat once or twice? And for those people doing this, I'd be interested to see your hands of who does single, who does double tap. I mean,
this is about augmenting the energy. So the user overrides the computer, which tells you how to treat, and you treat an area twice. And I think most of us have started doing that, particularly for the anterior margin and when you're treating on the tumor. I don't do it next to the rectum, but I think it augments the dose. My anecdotal response is that you get really nice ablations as a result, deep, dark ablations.
Samir?
Yeah, I think the double tap, I use double tap selectively, but it gets back to that same thing Siri was talking about. With HIFU, due to tissue movement expansion, you get patchy confluence. So intuitively, if you treat twice, you remove some of the confluence issues, you deliver more energy. I think it's generally safe, so we've done it, yeah.
And focal versus hemigland. I have a sense that people are moving to a hemigland. I could be wrong with about that, but I get a sense that people are moving to that. Is that, Mark?
No, I mean, we're still very focal, but we're pretty generous on the margins that we apply. Okay. You normally end up treating a quarter of the gland, but unless the prostate's enormous, which I try and avoid, because you always push them into retention. But, for an average prostate, it's usually a quarter or sixth of the prostate.
And Samir?
Yeah, I agree with that. I tend to do a 10 millimeter margin, regardless of location. But as you know, a 10 millimeter margin circumferentially is going to end up being a hemi in probably at least a third of the patients.
And let me ask you quickly both about apical lesions. What kind of margin do you need on an apical lesion? How close is the urethra? I mean, how do you evaluate an apical lesion versus a midgland and base?
So for me, apex depends on anterior, posterior apex. Anterior apical lesions are not good for HIFU because of the position of the urethra and the risk of stricture and the energy delivery. But you can sometimes treat them with cryoablation. Posterior lesions that are in the apex but lateral can be effectively treated with HIFU.
And do you have a millimeter distance from the urethra that you look to, or is it?
I treat up to the urethra. I don't have a problem partially treating the urethra. You don't want to circumferentially treat the urethra. Interestingly, the vapor technology that we have in trial now, you can treat distal apical lesions pretty safely there as well. So as long as you're not circumferentially injuring the urethra, I think treating up or partially into the urethra is acceptable.
Yeah. I agree. With the apex is about margins. I like a good 5 millimeter distal margin on that. Otherwise, you get, and it's the gadolinium sequence that gives you the best assessment of the true extent of the tumor at the apex. Otherwise, the recurrence tends to be curvilinear around the sphincter, and then they're hard to treat.
And if it's tracking along the urethra, which you often see, I tell those patients they're not focal candidates.
Someone asked me about surgery after focal ablation, and I'm developing an experience on this. And to let people know that actually those cases go very well. I've only had really 2 cases from outside institutions where we've had challenges, but generally these patients do very well, and the surgery is certainly not anything like you do when you have to take care of a patient's failed radiation. Last question?
Yeah, Samir, does the Vanquish system have a transperineal application for the vapor, or is it only transurethral?
Currently, it's only transurethral.
Well, I think that's our time, correct? We're done.
We are.
Thank you very much.
Thank you.
Yeah.